Welcome to the next episode of the VSP podcast. Today we're going to be interviewing Dr. Brian Capogna, who is not only a friend, but he works for Orthopaedic Associates of Manhasset. We're excited to have him on to talk about youth baseball, athletes in general, his experiences, and to also hear about what he's going to say at the VSP Baseball Summit, which is going to be Saturday, November 22nd. If you are interested in signing up, please click the link in the bio, and we'll see you there. Let's jump into the episode. Brian, thanks for coming on.
Thank you for having me.
So the audience is very curious here about you. We want to know a little bit about your history. How do you got into what you got into? My wife being a resident right now, I know how crazy it must have been getting to where you are. But hopefully, everything's moving in the right direction, and the experiences you've had, I'm sure are super interesting, and people definitely want to hear about them. So share that.
Sure. No, thank you for having me. Great to be here. So I'm an orthopedic surgeon, subspecialty in sports medicine. So the vast majority of my practice focuses on treating young athletes, both non-operatively and operatively. What got me into it? Listen, it's an outcomes-driven field, right? The beautiful thing about orthopedic surgery is that you often identify a problem that you can fix. The outcomes are generally good. Athletes generally do very well. And again, it's a results-driven field that I think the vast majority of the people do very well from. What got me interested, believe it or not, it wasn't sports that got me interested to start. I had two grandparents who underwent knee replacement surgery when I was in high school, and that was sort of the thing that got me at least interested in surgery as a career field.
Yeah.
I sort of always had interest in science and medicine as a career path, but orthopedic surgery sort of came to light when I saw the functional recovery of my grandparents, actually. When it came down to it in medical school, orthopedic surgery became for me. I trained at NYU, formerly known as Hospital for Joint Diseases, now NYU Langone Orthopedic Hospital. I graduated there in 2017, and then after that went down to Birmingham, Alabama for a year and trained under James Andrews, Lyle Kane, Benton Emblem, and Jeff Dugas at the ASMI Sports Medicine Institute. Had a great year there, but have family ties to Long Island, so came back, right, as a lot of people
Everyone
do.
does.
Yeah, if you're from Long Island, you're from Long Island, right?
Yeah.
So we did it. Sports for me was, about experience treating the athletes in residency. Again, I loved the surgery. I loved arthroscopy. Arthroscopy for me was sort of an organic thing. Grew up playing video games as a kid, so a lot of manual things, seeing stuff on a screen, and it just sort of followed suit for the technical skills required for that type of surgery.
Yeah.
I like dealing with young people. I like dealing with young athletes. And so for me, it was just an organic pursuit compared to any other field in orthopedic surgery. So now that I'm back, I love working with the athletes at the high schools we cover from all sports, but specifically baseball as well. And so, yeah, that's why I'm here.
Okay, cool. Now, can you share a little bit about what your specialties are in terms of surgeries? Maybe the types of athletes that you've been working with lately?
Yeah, so sports medicine in general is less of a body part type specialty and more of a type of surgery and a type of pathology that we're dealing with. So we're often dealing with athletes who have injured a tendon or had a soft tissue injury that requires repair or reconstruction. Good examples would be like a young athlete, football player with an ACL tear. Again, talking about baseball, we're talking about shoulder injuries, labral tears, slap tears, elbow injuries, Tommy John tears, otherwise known as the UCL ligament. And again, it doesn't just extend to younger athletes. I see weekend warriors, older individuals playing pickleball. That's the classic nowadays, knee trauma, meniscus tears, rotator cuff tears. So, that's the focus of the types of surgeries. A lot of it is done in a minimally invasive way, so arthroscopically with a camera. And so that's what I see, and that's what I like to see.
Okay. Now, what brought you to OAM?
OAM was, in my opinion, the premier private practice in Nassau County, where I'm from. I grew up in Farmingdale. I actually went to St. Anthony's High School, so out here in Suffolk. So I sort of have ties to both. Family guy, and I sort of wanted to be close to family and be in a practice that I saw myself growing and that already had a footprint in the community. And I would say OAM had all those things.
Yeah, nice. And now, how often do you spend? Because I know obviously you guys have the office in Great Neck, right?
Correct.
And then now in Huntington, not too long, you guys moved here. How do you split your time between those?
Yeah, so the Huntington office is relatively new in the last 2.5 to 3 years. The majority of my practice time, at least in the office, I'm probably 3 days a week, 2 to 3 days a week in the Great Neck office, 1 day a week in the Huntington office, with an operative day or two sprinkled in throughout the week. So that's the split of the time. I mean, we're looking to expand further. I know we've actually had conversation about building out another office somewhere in Bethpage or Farmingdale, right?
Okay.
So we're a practice that's continuing to grow with the times and just keep touching as many athlete lives as we can through football coverage and sports coverage. And, we're still actively participating in those things, currently.
Nice. So you said growing with the times. Now, since you graduated medical school, how much evolution and change has happened, in your experience?
Yeah, there's been a lot more talk of the biology of healing, right? So there's been certain advancements in tissue repair concepts, whether you're talking about biologics such as PRP, which is a platelet plasma injection, either as non-operative treatment or as an augment to a certain type of repair. There's been advancements in implant technology, sort of moving away from like more metal types of implants to more resorbable implants or more biologically coded sutures that in theory become incorporated into our soft tissues. One example that we use to augment with Tommy John repairs is a suture structure called the internal brace, which is added to the strength and stability of repairs that we do.
Yeah.
And so, there's definitely been advancements, and I would say that, a lot of the interest, at least in the orthopedic world right now, is on biologics as a way to enhance our repairs.
Nice. Now, how do you stay up with the times? Like, do you have a network, a group? Like, how do you keep up with your education?
Yeah, so, I think if you talked about it in the day, it would be just journal articles, right?
Okay.
And to a certain extent, that still holds true. But the way that information is disseminated, as you know, as advanced, there's podcast conversations about journal articles. There's, obviously meetings that you can attend, which I continue to attend to keep up with the times, see different advancements. Do labs, specifically on newer techniques, right? Tested in the lab before you put it in the body, right?
Yeah.
So this is stuff that, we view as the continuation of our education, right?
Yeah.
At least the way it works in surgery is, if you're not advancing, you're shrinking, right?
Yeah.
So if you're not keeping up with these sort of things, then you're probably, sort of falling behind on what you could provide to your patients.
Yeah. Now, you also spoke about weekend warriors and then obviously work with youth athletes. Do you have a different approach when it comes to one or the other, or is it pretty similar? Like,
yeah, I think, you sort of have to cater to the person you're talking to,
okay.
right? There are certain injuries in some older people. So, for example, like low-grade rotator cuff tears can be like an age-appropriate finding.
Okay.
We don't necessarily treat that type of injury the same way we treat a 17-year-old football player with an ACL tear.
Got it.
We understand healing potentials. We understand functional, the body's functional ability to compensate for certain injuries.
Yeah.
And certain injuries can be compensated for and others really can't, right? So, and so that certainly comes into consideration. We consider the sport and the injury. We consider the timing of the injury, especially with relation to baseball. That's a big part.
Yeah.
In an effort not to lose a season, for example, you might forego some conservative treatment. Like, let's say if somebody has a Tommy John ligament injury that you understand has a pretty low chance of healing, like a distal tear, you might suggest surgery knowing that that's the best option to allow them to recover in time for an upcoming season, if the timeline makes sense, right? And that's a conversation you have with the athlete, and that's the conversation you have with the parent, right? So it's never really the surgeon making the decision. It's a team-based decision. I think that's hugely important to have somebody, to have everybody on the same page. That's, really the Andrews philosophy. That's what I took from Birmingham. It's really like sort of ingraining yourself in that family's thinking as to how they want to go about treating their son or daughter.
So obviously every case is different. Now, I guess a common example that my friends and I were talking about was Malik Neighbors. So he had an ACL tear, and they just, he got hurt weeks ago, but they just did surgery. Like what would, I mean, I don't know if it's different with the ACL or maybe, with rotator cuff, you may wait to do surgery. Why do they wait so long? Just out of curiosity.
Yeah, so a couple of reasons for that. So in my practice, I mean, ECLs walk in very different shape, depending on the extent of the pivot, the trauma of the injury, whether it's a high energy pivoting injury to the knee or a low energy pivoting injury to the knee. There are some people who walk in and they know they've done something wrong, right? They felt a huge pop. Their knee hugely swollen. They can't move at all. They can't put pressure on it. They're walking in on crutches thinking they broke their knee. It's not often a fracture, right? But those are patients who are walking in with a very, what I call biologically inflamed environment in their knee. That situation, we looked at certain studies that show that going into surgery right away may not be in the best interest of that athlete. Although it sounds great to go quick, at least the adage I still go by is that the more inflamed and painful you are going in, likely the more inflamed and painful you are going to be coming out. So that would be a situation, for example, where if somebody doesn't have at least close to full extension and reasonable flexion, they're still exquisitely painful with any range of motion. You might delay that person, brace them, put them on high-dose anti-inflammatories for a couple of weeks, ice them, prehab them, right? Get them with a reputable trainer or therapist to start achieving at least some semblance of, quad activation and mobility, and then bring them to surgery. The converse to that is I've had some patients walk in, twist their knee and not think anything of it, check their exam, they're loose, and confirm an ACL tear on MRI. If they have full motion and minimal pain, I could take that person to surgery tomorrow. Right? But those are two very different scenarios.
Got it. Now, we work with a ton of 12, 14-year-old kids, a lot of baseball players, and kid will come to me and be like, I have a little elbow pain. Do you think I need to get checked? And I'm like, and I'm highly conservative. I'm like, you know what? In my experience, every single time that a kid has pain, something potentially is wrong, right? So I always be like, go get it checked out. I'd give Fred's number, obviously. But go talk to Fred. Go get checked out. And unfortunately, many of the times, it results in, maybe it's, they're out for a certain amount of time or whatever the case may be. But when do you suggest, hey, you should go get checked out? Is it a tightness thing? Is it a pain thing? Obviously, it's case by case, but people are always asking, when do I go get checked?
Yeah, I think for me, the first obvious reason to send someone immediately is an acute injury, right? So if they're throwing and they feel a pop and it's immediate, that to me is check out. Other types of pain that are maybe a little bit more gradual, I think it's really a judgment call, right? I think there's a certain amount of discomfort that you could attribute to overuse. I mean, when you look in the pediatric population, there's some studies that show that overuse is responsible for 80% of pediatric pain. Now, it's not the case for everybody, right? But for me, when you talk about pain that has started over time, it's the timeline. Is it over 2 weeks or under 2 weeks? Over 2 weeks, not responding to reasonable rest and icing and stretching and anti-inflammatories, that's sort of my cue to say, hey, listen, this person should probably be evaluated.
Got it. Now, it's obviously, Little League, elbow, Little League shoulder. What is that? And I guess in simple terms, so we don't confuse our audience, what is happening? Why is that? Why does this pain happen?
Yeah, so those are overuse injuries. When we're talking about the pediatric population, they have the added benefit of having their growth plates open, right? That is just another structure prone to stress and inflammation. Bony structures typically. With overuse and throwing and the torque that's responsible specifically for Little League shoulder, you start to see inflammation in that growth plate.
Got it.
Often not visible on X-ray, although sometimes it can be. More often diagnosed on MRI. And honestly, probably the best scenario because that's something that does get better, right? Something that generally gets better with resting, appropriate stretching and therapy, anti-inflammatories. Think of that like too much stress on an otherwise normal pediatric body, but not necessarily injury to any soft tissue structure that I need to talk about.
Yeah. Now I'm going to ask you the $1,000,000 question. How do we prevent these types of things? Like, what are some? Hey, this is a few things that you could do to hopefully you can't prevent everything, but a few things that you could do to put yourself in the best position, be healthy.
Yeah, I mean, it's probably multifactorial, so it's probably not any one thing that's the most important. It's thinking about all the things that we could possibly point to and say, these things can contribute and we should address them as best we can. There's been a lot of research on this with regard to pitch counts, pitching velocity, throwing curveballs like above or below a certain age. As far as my opinion, a couple of things have come to the forefront in the last, let's say, several decades. Sports specialization is a huge deal. In the last couple of decades, there's sort of been the death of the multi-sport athlete.
Yep.
You no longer have baseball players playing baseball in the spring and then running track in the fall and playing basketball in the winter. I'm a baseball player.
Yep.
And I play spring ball, summer ball, fall ball, winter ball, all year round.
Yep.
Right. So that's probably one of the keys. I mean, if you view the elbow and the shoulder as being something that has mileage to it, the more miles you put on the car per year and the higher intensity with which you're throwing, it's another factor, right? The radar gun has been, you never go to like a combine and not see a radar gun.
Yeah.
Somebody's throwing, they're measuring their speed, and that's a huge deal. Kids won't even get looks if they're under a certain speed.
Yep.
And if you look at the average velocity of a fastball in the last 30 years, it's probably gone up from an average of 92 to 96. I'm not sure what the recent data is, but let's face it, it's just getting faster.
Yep.
I mean, guys are throwing 102, 104.
Yeah, it is crazy.
You didn't really hear about that from, let's say, Greg Maddux and Tom Ladd.
Yes.
Guys who mastered control and velocity differential, but weren't throwing 105.
Correct.
Right. So there's a certain amount of torque that puts on ligaments. The higher the velocity, the higher the torque.
Yeah.
Those are probably the biggest two factors.
Yeah.
They've actually done some studies more recently on curveballs. Not really conclusive evidence. I'm not really a big believer in that. I just think it's mileage, it's velocity, it's probably career specialization at a young age.
Yeah.
And that's probably responsible for the rise.
Well, you say mileage, people are questioning why are so many people getting hurt right now in the majors and whatnot, and it keeps going up and up. And you said it, like people are just playing so much, it just compounds over time. Yeah. And it's kind of sad, especially when I see kids, we work with a lot of baseball, only athletes at 13, 14 years old. I'm like, what are we doing? They're going from the winter training, jumping into the spring, they have summer ball, then they have fall ball. Yeah. And they never have a break. And they're immediately right into their winter training. And, I try to do my best to let them know, hey, we need time. I try to work with their parents and whatnot. But at the end of the day, the coaches and organization are like, hey, if you want to play at the top level,
you got to do this.
Got to do it. Yeah. And it is kind of sad. And I'm hoping that there will be a shift, because the sport of baseball especially is plagued by injuries. Hopefully there will be a bit of a shift, but I don't know.
Yeah, and the other thing to consider is just considering the whole body as a part of the athlete, right? So it's not just your arm, right? It's not just the mechanics of the way you throw. It's sort of like a ground up philosophy, and we've spoken about that, right? So, if you're talking about a patient that has elbow pain and you're not examining their shoulder and you're not checking for a tight posterior capsule, which can contribute to torque and medial stress on the elbow. If you're not looking at their core mechanics, if you're not looking at their rotator cuff strength, which is sort of that stability factor for when they're throwing, then again, those are things that we think contribute not just to Tommy John injury, but injury in general, especially in a developing person, right? I often joke with parents. I go, listen, this is a 14-year-old boy who's growing into a man's body, but throwing at a man's velocity.
Yeah.
Right? It's almost like his body hasn't caught up to his throwing velocity yet. So when I meet 15-year-old kids throwing 85 miles an hour, with open growth plates, there's something to be said for that level of stress on the body.
Yeah. I mean, I guess the body can only take so much, right? And you can't strength train so much to prevent anything like that because, fortunately, there's a lot of people that believe that, strength training will help them, doing all the arm care will help them. But at the end of the day, like you were saying, the mileage and the workload management, sometimes it just catches up to you.
There's a happy medium, and it takes buy-in. I think it's tough, when you look at, just the world. It's it's tough competition.
Yep.
Right? So I get that perspective on it 100%. And, and there is something to be said for like us training, through that stuff. Probably some of the best athletes we've ever seen, like in the history of sports.
Mm-hmm.
But the converse to that is, we do, or at least we think we are seeing more injuries with that as well.
Yep. Now, a lot of parents always ask me like what they should be doing, whether it's baseball or any sport, to prepare their bodies to prevent themselves from injury. But are there like things outside of the medical realm that they should be doing, whether it's like nutrition, strength training that you've seen or heard about?
Yeah, I mean, from a nutritional standpoint, I mean, the one thing I ask athletes when they come in, especially if they're like running distance athletes, right, is like, just what is your nutrition?
Yeah.
I mean, are you taking appropriate calories for the amount of expenditure that you're doing in a day? Do you have appropriate balance of protein and carbs and fats? Are you not just drinking Red Bull and eating McDonald's and then showing up to train and expecting functional recovery and functional results, from that type of nutrition, right? So, I don't think that there's one perfect nutritional balance for everybody, but it's got to be somewhat balanced, right? It's got to be in moderation, and you have to be taking in calories, right? And when you look at a guy like Michael Phelps, training for the Olympics, he's eating what, 5,000-6,000 calories a day, hopefully in a balanced eating, right? But there's something to be said for that, having an appropriate nutritional balance, or meeting with a nutrition if you think that's the case, meeting with a nutritionist. As far as prevention things, I mean, again, I just think that like there's a certain amount you can control. I mean, injury does happen. We can't prevent every injury. I often talk to parents if they're really interested in their kids pitching about, sort of in a way trying to restrict them a bit with mileage or having them pitch in certain seasons. Even sort of delaying their start of pitching, right? I mean, make your kid an athlete. Make him strong and flexible and a power athlete in every other way. And if they start throwing in, let's say late middle school, early high school, as opposed to earlier than that, a lot of times those mechanics have developed enough that like you might at least assume that they'd have lower injury rates. I think that's hard to prove right now. And, we still need more research on that. But, a lot of it, at least my conversation with the parents is mileage, right? And it's year-round throwing and honestly the velocity.
Now, mechanics-wise, are there things that you've seen in studies and whatnot that have led to more injuries, or it's too hard to say?
I don't think that there's any really good data to support that like somebody throwing sidearm or overhand submarine has a higher rate. There's some biomechanical data looking at shoulder pathology, like for example, so when athletes come in, even with elbow pain, I always check their shoulder. Right? For me, like examining that kinetic chain from the shoulder down is hugely important because more often than not, what you'll find for most pitchers especially is that due to the repetitive throwing motion and the mechanics of the shoulder, their posterior capsule of their shoulder is often very, very tight and their anterior capsule is often very, very loose. So I'll often lay an athlete down on the table and examine their internal and external rotation compared to the other side in front of the parent and actually demonstrate for them that their throwing arm internally rotates maybe 10, 15 degrees and the non-throwing arm goes in 60 or 70. And that differential, that posterior capsule tightness, we know leads to a pathology called internal impingement of the shoulder, where essentially the ball on the socket is sort of functioning at like a higher pivot point. So what that does essentially is you go to arc your shoulder up to throw, the undersurface of your rotator cuff is actually rubbing against the posterior superior labrum. And we can see that pathology on MRI. I mean, even if I don't examine someone, if I see that combination of things, a little undersurface rotator cuff tearing and a posterior superior labral blunting or tear, I don't even have to examine the athlete to say, I bet you your shoulder's tight. Right? So, that part of it, I think is important. I think that, if you're not also addressing any, even if there's no pain, by the way, but shoulder mechanical issues with relation to elbow, that's just another thing.
That was, I never heard that before. That was pretty interesting. Now, moving into the Baseball Performance Summit, could you give us a few areas that you're going to be going over? What are people going to get, from you speaking?
Yeah, so my focus is going to be on Tommy John ligament tears and sort of where we've come from and where we are now. So we'll talk a little bit about the history, Tommy John as a player, Frank Jobe, who's the originator of the surgery, out in California.
How long ago did they start doing Tommy John?
Like the 70s.
Oh, wow, okay.
I forget if it was 71 or 72, but early 70s. Believe it or not, it was somewhat of like an investigational surgery.
Okay.
Imagine doing a surgery on a professional athlete you just invented. Right?
That would be wild.
But that was medicine in the 60s and 70s.
Yeah.
I mean, these were world-class surgeons doing what they thought, based on their brilliance, was the best surgery for someone. And, I think it came down to it where Tommy John had either the option of doing a surgery that could help him or no surgery and ending his career. And he chose the former, right?
Mm-hmm.
Let me do a surgery and rehab and see how this goes with a surgeon I trust. And, obviously that ended up being very successful because it's led to where we are now.
Yeah.
A reconstruction surgery having 45 to 50 years of mileage behind it. It's led to advancements in our ideas about possibly even repairing that ligament. So that's sort of where we are at the forefront now, is taking certain types of tears, avulsions off of either side of the bone, or partial tears off of either side of the bone, and being able to repair those and add in a collagen-coated suture to help augment that repair. So that was something that I was exposed to through my great mentors at ASMI, where they sort of helped advance that over the last decade. And the outcomes of that have been great. I mean, I think at the end of the day, what we're looking for with surgery is not a surgery that's necessarily better than Tommy John surgery, because that's hard. I mean, it is a very successful surgery. I think there are frustrations with the recovery time, often the biggest issue. Return to sport being anywhere from, 12 to 18 months. Professional athletes missing 2 seasons. And so at least what we're finding with these repairs with internal brace for these very select cases is that the rehab can be shorter.
Okay.
Right. So you're looking at possible recovery times that are cut in half. Right. So returning athletes to throwing anywhere, at competitive levels, anywhere from 7 to 9 months.
Okay.
So that's where a lot of the focus has been more recently. Not to say that reconstruction has lost its utility. There are certain tears that can't be repaired. Where the tissue quality is not good enough for repair.
Got it.
Certain tears in the middle of the tendon really can't be repaired. And so you have to be very cautious with your selection there. But so repair has sort of come to the forefront.
Now
that'll be a focus of the talk.
Not to talk too much about this, but the recovery. So what is if you were to envision, like, hey, I'm going to write out the perfect way for an athlete to recover from Tommy John surgery, what would that kind of look like?
Yeah, I mean, it's not easy taking someone who sports could be a huge portion of their life and basically saying, hey, you can't do that for a year, right? At least the way I try and sort of sell the recovery to an athlete is make this your sport, right? I mean, you are so intense and so good at what you do. That's what makes you a good athlete, whether it be soccer, baseball, football, whatever. I mean, there's a certain amount of training that goes into that outside of injury. That's why you have athletes here.
Exactly.
Right? Not all these kids are injured. They're here because they want to be here, because they know that doing these things and focusing on these things and being dedicated to these things makes them better athletes.
Exactly.
Rehab from surgeries is very similar, right? I mean, you're starting in a little bit of a hole because you've had a surgery. Your end goal is to be a better athlete, right? You want to recover from your surgery. If you sell it to them like any other thing that they have to achieve and sort of hump over to get to where they want to be, I think they buy in more. And so that's what I try and impart on them. Just think of it like any other training.
No, that's awesome. So I've taken up a lot of your time, but I want to do one more thing. So I'm going to call this Fred's Lightning Question Round, okay?
Okay.
So I'm going to ask you a series of questions, and you have to answer whatever comes to mind first.
One word, or do I get multiple words?
You get multiple words.
Okay.
Yeah, I'll be nice.
Some people do one-word lightning rounds, like one word response.
I'll be nice. Okay, are you ready?
Go ahead.
3, 2, 1, here we go. Which actor would play you in a movie about your life story?
I don't know. My life Troy. So I don't know. I've gotten like Freddie Prinze Jr. before.
Okay,
Like,
all right.
I don't see it.
Okay.
Right? But like I don't see it.
Okay,
Right? And
right.
also,
Hey, it works.
I don't know that works with a life story. I don't know.
I don't know.
This is the question you have to answer. I don't know.
I like it. All right, so Freddie. Next, top 3 must-have songs in the OR.
Oh God, pretty much anything Chili Peppers.
Okay,
I'm more of a rock guy.
Yeah, I like it.
But I mean, let me be this way. A happy staff is a happy surgeon.
Yeah.
I generally tell my staff, what do you guys want to listen to? Let's just get this ball rolling. But if I had to choose, I would just do Spotify, Chili Peppers Radio. It's a great mix.
I'm all about it.
Any band similar to that, it's got good vibes, and it sort of keeps the vibes going in the OR.
Okay. What's an aspect of medicine that wasn't covered in your training that you've had to continually master in your practice?
Aspect not covered in training. All the documentation. That's
Okay.
probably what every
Yeah.
surgeon is going to say, because
Yeah.
like you're in your training and you're saying to yourself, well, I have to learn how to treat athletes. I need to know all the pathology. I have to learn how to do surgery. No one talks to you about the notes and the computer work.
Oh, yeah.
That's a joke of an answer, but I think that, if I had to talk about one thing that maybe we didn't focus on as much with athletes is the psychology component.
Yeah.
Like, I think that's a great example. There's been some newer studies on this, looking at like psychology of return to sports. At least the data that I've seen is like with ACLs, like they've basically done questionnaires. It's just self-reported things, right? But like questions like, how confident are you in your knee?
Yeah.
How worried were you returning to play?
Yeah.
What is your perceived level of strength for one leg compared to the other side? And at least what a couple of studies have shown, that if you self-report as not being ready, you're probably not ready, right? And the incidence rate of re-injury goes up with that. And that's irrespective of timeline of return to play.
Mm-hmm.
Like they've also looked at that 9-month mark specifically for ACLs, so as being sort of like a benchmark.
Yeah.
But even athletes returned after 9 months who weren't psychologically ready, I think there's something to that.
Yeah.
If you see them get re-injured, there may be something to that.
Without a doubt. All right. Favorite Long Island restaurant?
Favorite Long Island restaurant? Fried and Cooper.
Okay. Can't go wrong.
Where all the guys in the group love to go. Hashtag Cajun ribeye. That's my.
That's great. Great dish.
Yep, there
great
we go.
dish.
That's my place. That's my birthday dinner every year with my wife.
Love it.
Every
Okay.
year.
All right. Maybe I'll come.
It's the best.
What sports were you involved in as a young athlete, and do you still play now?
I played baseball growing up. I played ice hockey when I was very young, and roller hockey, inline hockey at a couple of rinks throughout Long Island through high school.
Okay.
I ran track in high school, cross country specifically.
Multi-sport athlete.
Multi-sport
Okay.
athlete. Not the best runner, but hey, listen, I was there. And in college, just focused on the academics.
Okay.
Do I still play now? Nothing organized. Basic working out at the gym.
Okay. All right. Stay active.
Two daughters, right?
Yeah, that's gotta keep you going.
I'm just trying to get to the gym.
I don't blame you, man. All right. What are some of your most successful professional relationships? Which ones do you want to improve?
Successful professional relationships. I would say you are a very successful professional relationship. We work well together. I work well together with several therapists throughout Long Island. Working with even just other physicians from other specialties, primary care doctors, primary care sports medicine doctors. A lot of referrals from working with athletes at the different high schools we work at. So all the athletic trainers there who are basically, they're boots on the ground, man. I mean, you are seeing these athletes way more often than we are, and managing them in like the immediate phases of injury, right? So, in my world, that's probably the biggest one, right? Is therapists seeing people who come in, who are injured, trainers and other advanced professionals seeing athletes, come in. A kid here could say, hey, listen, my shoulder hurts, my elbow hurts, and knowing that timeline for a referral. And then the trainers on the sidelines, right? I mean, they're there, and they're seeing the acute injuries, and those are probably the best connections. Yeah.
Oh, that's nice. What would you tell your younger self at the beginning of med school?
I tell my younger self at the beginning of med school, it's going to be fine. It's going to be worth it. That's a big one. See that light at the end of the tunnel. Enjoy the ride, because although it changes, it's not any easier, right? It's just different difficulties. Different things are difficult, right? it's not easy being the one in charge as opposed to the one training, right?
Yeah.
You're learning, and that seems hard, but not a lot of responsibility when you're in training because you have an attending there.
Mm-hmm.
So, yeah, I mean, I think there were certain experiences and certain things I did in training and cases I saw that, like, I'll never see again, that I'm grateful for because it's not my specialty, but like, we did some incredible things, and I'll always remember being on trauma rotations, even though I don't do a lot of it anymore.
Yeah.
I mean, as an orthopedic surgeon, you sort of like love that stuff, right?
Yeah.
I mean, fixing femurs and fixing tibias and being on call in level 1 trauma centers and
that's crazy.
Being in the emergency room, like, it was like an awesome thing to be a part of.
Yeah.
And I think I would tell my younger self to like have, let's say, enjoyed that more.
Yeah.
Right, because it was really a great experience.
Okay. Very cool. What podcast do you listen to right now?
So I'm a big Spit and Chicklets guy, right? So
okay.
I
Are you a Ranger or?
I'm an Islanders fan.
Oh.
So, and we're doing okay, right?
Are you going to the Ranger Islander game in MSG, November 8th?
Should we go?
I'm going, so you should go.
I will tell you that is my daughter's birthday.
Okay,
so,
all right.
Birthday party at least. So probably not. But yeah, I mean, listen, huge Islanders fan. Hockey is pretty much my primary sport.
Okay.
Grew up a Mets fan, Jets fan, and a Knicks fan. So a lot of struggle.
Yeah, it's brutal.
That
brutal
is what
there.
it is. The Islanders are decent. Matty Schaefer is our savior.
Yeah, he is. He's awesome.
He loves Long Island. He loves to be here, so I love him. And yeah, that's
okay. All right. What favorite movie of all time?
So I view comedy and drama in two very different categories. I think when you say what's the best movie ever, you have to mean drama.
Okay.
Probably The Shawshank Redemption.
Okay. Wow.
Probably. I mean, there's a lot of good movies, but like universally loved by like everybody who watches it. How do you not love Shawshank?
Okay, I agree. Are you currently reading any books?
So I do a lot of audiobooks.
Okay, I'm with you on that. I'm with you.
Because that's where the time is. It's in the car.
I agree. I agree.
Big audiobook guy. Recently, I've done Schwarzenegger's autobiography, which was awesome. Also narrated by him.
Oh, wow, that's awesome.
Which was even more awesome.
That's better.
Guy's life was incredible. Financial books, basic stuff like that, life stuff. I try not to do as many medicine podcasts.
Yeah.
But like, and books, same thing. Like, again, journal articles, fine, meetings,
correct.
fine, but like, I'm not reading too many medically, oriented books just because I got to get out. You got to do something different.
And last question, if somebody wants to find you, get treated by you, learn a little bit about you, where can they go?
Yeah, so we're at Orthopaedic Associates of Manhasset, 2 locations, 600 Northern Boulevard in Great Neck and Huntington, 532 New York Avenue. We have a website. You could either just Google my name, basic stuff, Brian Capogna, MD. We have the ability now to sign up online to get an appointment through our website, or you can call the main office line. It's 516-627-8717. We're on the socials. I have an Instagram that is half medicine stuff and half my daughter's doing stuff and reposts from my wife. It's Dr. Sports New York.
Okay, nice. All right. Well, if you want to see Dr. Capogna live, come to our summit Saturday, November 22nd, 9 a.m. here at VSP. Again, tickets are going to be in our bio. It's going to be awesome. Hope to see you there. Doctor, thank you for coming on.
Thank you, man. Appreciate it.